Now, I've had a fairly entertaining 24 hours because I've been asked to give this talk today. I'm doing a webinar for 700 for some big thing on Thursday. I'm running the RSM next week, and a tree's just come down in the churchyard and taken out all of my phone lines and broadband lines. So we've been trying to get lots of whatever these funny boxes are to do virtual thingies, and we've managed to get one that's working. Now, what it means is it's not going to be as perfect as the presentations normally are when I do them online like this. So if there's a little bit of jumpiness, can you just forgive me? But I thought it was better, since you've made the effort to come and listen, that we get going now. And then if you want to ask any questions at the end, you're very welcome. So what we'll do, I'm just going to go through a little bit more slowly than I might normally, because I think there'll probably be a delay of a few seconds, but we'll have a lot to talk about here. This is my long-suffering manager in the audiology department, who is absolutely wonderful. And this is a TRV chair that we're going to talk about a little bit later on, which is great for BPPV. If anyone's got epilepsy, can you just look away for this particular video? I hope it shows for you. Again, we can do lots of stuff on its Vertex posturography, which is a fantastic way of taking apart various balance disorders. So what we're going to do is go through a brief introduction as to why balance medicine is so important and why it's my life. But you do need it in the exam as well. How I think about balance patients, which I hope will make it a little easier for you when you see them. And my sort of goal is, at the end of this, rather than putting your head in your hands or trying to shuffle the notes off to another registrar in clinic, that you'll be looking forward to seeing a balanced patient at the end and working through their problems. So we're going to look at 3 of the key disorders. For those of you doing the exam, I'll throw in some new stuff that you might get asked about. And for those of you who are not doing the exam, hopefully there's some new stuff here which will be useful for you. So why are you here? Well, balance disorders and dizziness are very common. About 5% of the population see their GP every year or experience dizziness every year with dizziness. And if you think about a county like Leicester, we've got just under 1 million people here. That's 50,000 people a year getting dizziness or vestibular dizziness just in our county alone. And a third of us will see our GP before the age of 65 with dizziness, and it's the commonest reason to see a GP over the age of 75. So it's a big problem, and there's lots of work out there. Now, since I've been in Leicester, which is now 16 years, it's a long time since Sandeep and I were together, though he hasn't changed at all, of course. We can see 7,000 patients appointments a year. When I joined, we had about 1,400, so we've really grown it. But you can see, if you can compare the 7,000 a year to the 50,000 need a year, we're not touching the surface. And there are really long delays in diagnosing balanced patients. They go around lots of different departments, lots of different specialities. And from a patient perspective, no one else can see the problem they're having. So it's really distressing for them. And being given a diagnosis and an appropriate treatment is absolutely life-changing for them. So let's think how I address the balanced patient. The first thing to say, whenever I give a talk on balance medicine, is it's a bit like giving a talk on a textbook of medicine. So almost anything can cause dizziness. And here's a schemata I put together with Professor of Computing, Andrew Hugill at the university. This is the very, very early origins of an artificial intelligence-based dizziness search engine, if you like, or a diagnostic engine that we're putting together. So if you think of your patients both from an anatomical, pathological perspective and from a symptomatic perspective, it's useful. So has your patient got vertigo, episodes of spinning or giddiness, and a sensation of motion? Does your patient just feel unsteady and off balance, or are they lightheaded? That's a good starting place, because the vertigo, you're likely to get a, you're likely to get a diagnosis in the inner ear. You've got a whole range of them here, or in the central nervous system, and relatively unlikely to get other causes of it. And if you want to Google balance disorder spectrum, and you can click on each of these diagnoses, and you'll come up with a brief summary of it. And if and I ever have time, we'll sort of write a textbook behind each of these banners, but we haven't done that yet. And then with disequilibrium, you're looking at a different group of conditions, bilateral vestibular hypofunction, ototoxicity, and so on. But you see we're getting some more central problems and adding in a number of psychological and other conditions, one of which I'm going to discuss in more detail. And then lightheadedness changes things very much. You're not likely to have a vestibular disorder with lightheadedness. It's more likely to be cardiovascular or maybe an anxiety-related disorder. So that's just a useful way. And then you can see the pathological sieve. Is it vestibular in origin? Is it central nervous, cardiovascular, or the whole range of other things it might be? So the second thing I want you to think about when you see your balanced patient, and this is probably the best learning point of all, is divide your patients into those with episodic vertigo and those with chronic imbalance, chronic disequilibrium. And once you've started doing that, you've made a really big stride forward to getting your diagnosis. So of the recurrent vertigo syndromes, there's a whole mass of them that we can go through, but 3 are going to make up the great majority of patients that you see. So BPPV, accounting for about 1% of the population, Menieres accounting for about 1 in 1,000 patients, sorry, 1 in 1,000 population, and vestibular migraine, the elephant in the room, again accounting for about 1% of the population, and that's a lecture on its own. And of course, they often occur together. And then you've got the chronic disequilibrium of vestibulopathy related to the ear or brain or lots of things together. And then this enigmatic condition of PPPD, persistent postural-perceptual dizziness, that we're going to go through a bit later on. So let's have a look at BPPV to start with. You know the symptoms of BPPV. I get dizzy, doctor, when I lie down in bed, roll over, look up, get up in the morning, I spin for seconds or a minute, it's very intense, I feel dreadful, and it settles when I'm still. I'm better propped up in bed, I'm bad putting cups up on the shelf, going to the hairdressers, going to the dentist, that sort of thing. Well, yeah, that's all true, but that's not necessarily how your patient presents, because patients with BPPV adapt to their symptoms. So they don't lie flat or roll over or look up. They use extra pillows in bed. So how many pillows do you use? If your patient's using 3 or 4 pillows in bed for their dizziness, it's going to be BPPV, almost certainly. But they also complain of disequilibrium. So when they're walking, they feel woozy and unsteady and a bit strange. And then you treat their BPPV, and very often that imbalance just gets immediately better, straight away. So don't be fooled by other symptoms. You can see that the lifetime prevalence is high. 1 in 50 of us will get it. And the 1-year incidence is really high, isn't it? Nearly 1 in 100 people. And it increases most definitely with age. I've got 2 8-year-olds with BPPV. I've operated on 2 ladies of 28, but the great majority are much, much older. And once you get into your 60s and beyond, it starts getting very common. And the concept I want to get over to you is that BPPV are not rocks in the inner ear. This is a biological living condition, a bit like osteoporosis. This is all a bit easy for you, but you know that the crystals arise in the utricle, and I always explain to the patients, these are real, we've all got them, and when you put your foot down on your new sports car as you accelerate, the inertia of the crystals being forced backwards stimulates movement of the eyes and so on, and makes you appreciate the acceleration. And these crystals break off, and by gravity go through the cross communale and then fall down here into the posterior semicircular canal in most patients. Occasionally they can go into the anterior canal, but they normally drop out on their own, and occasionally they can go into the horizontal or lateral canal. So that's where they go. And interestingly, it's not that long ago that John Epley was doing his work. It was in our lifetime. But here's the thing I want you to think about. These are not rocks of calcium. These are not inert grains of sand. You have this beautiful glycoprotein matrix, which is made of otolin, and it's different in different species, in a fish lateral line, in a human, whoever or wherever it is. And laid upon that is lots of calcium. And it produces this stereotypic otolith, of which we have very many, and each species has a different number. And as they shift, they can cause the classical symptoms of BPPV. Now, sometimes diagnostically, it's really difficult to get the diagnosis in these episodic vertigo syndromes. And you're wondering, is it Meniere's, is it PPPV, is it migraine? So something you can do is say to your patient, well, I'm not sure at the moment, but when you have your next attack, can you put your smartphone up against your face? And as you roll over one side and the other, just take a video of your eye movements. Or if you have an attack sitting up, take a video of your eye movements. And that's quite a neat thing to do. And then the way we treat it, this is one of our audiologists and old clinic managers, and you know the Epley maneuver, going from right to left and down again, and then sitting up and standing behind the patient afterwards, because they often feel like they're going to fall backwards. Brandt-Darragh exercises, you'll find a lot of the GPs give the patients the Brandt-Darragh exercises to start with. Now, the problem here is it's really rotten doing that, is if you've got bad BPPV, because you'll just make your patient really sick. So I'd really strongly suggest starting with starting with the Epley maneuver, use a Seamont maneuver if the crystals are difficult to shift, and then the Brandt-Darragh exercises can be used just to mop up a few of the last crystals. And this is the sort of thing that I want to teach you on face-to-face courses, whether it's at the Royal College of Surgeons, BSO course, which we're going to be running, by the way, in Cambridge in, I think it's March, April next year, or at the Leicester Balance course, which we've had to cancel this year because of obvious reasons, but we'll be running again next year. Now, you know all of that stuff. So what I wanted to do was add in 3 or 4 new things for you. Now, the first is the TRV chair. So here it is here. There are 2 in the UK. There's one in Leicester, and there's one at Royal National. That's where it was last time I saw it. And it's pretty dramatic, actually. And you can see how the patient's thrown around quite violently, and they're banged really hard against the floor to shift those otoconia. And do you see that? And that's very much like when you're doing a Seamont maneuver and you do a slam dunk and you slam the patient's head into the pillow to really try and dislodge those crystals. And because we've got video eye movement at the same time, it makes it very easy to distinguish between lateral canal, anterior canal, posterior canal, and indeed multi-canal. And you can see me over on this side looking absolutely terrified. It's not the most pleasant experience having it done. And you know, patients with cardiac problems or the very elderly, you may not want to do it. But it's a brilliant thing to do if you've got difficult to shift crystals. It works really well for that. And if you've got an elderly person, say, with kyphosis, who you're really struggling to turn over on the couch, you can strap them into the chair and you can get them going to any particular angle you want. So the TRV chair is a really good tool for intractable BPPV. Now, coming back to the theme of BPPV being a living condition, there is increasing evidence that vitamin D deficiency may be implicated in recurrent BPPV in particular. I mean, the commonest cause of it's going to be a head injury and getting older. Those are the two big causes. But there are definitely papers out there showing that BPPV is commoner in the winter. Those with recurrent BPPV are more likely to have a severe vitamin D deficiency. The papers showing that taking vitamin D will reduce your BPPV are less clear cut, but I think it's something many of us are recommending. And particularly at the moment, because of course, one of the other causes of BPPV is inactivity. So if you've had spinal surgery or a stroke and you're lying recovering at home, that's a time you'll get BPPV. Or in the case of many of my patients, when they're on a cruise in the Caribbean, they seem to lie back in their deck chair doing absolutely nothing. And that immobility gets the crystals to collect in there. But of course, at the moment, many people are housebound because of the lockdown, and presumably have become very significantly vitamin D deficient during that anyway. So recommending vitamin D at the moment is a doubly good thing to do. Now, there's another paper that it might be worth thinking about. I don't want you to talk about this in your exam, but there's a 2016 paper which has shown that if you use intratympanic steroids for BPPV, that's a bit weird, isn't it? For intractable vertigo, there's a reduction in the number of attacks afterwards. Now, the paper itself is a fairly small series, and I would be cautious on it. But again, you just get this feel that people are beginning to explore BPPV as a living, dynamic condition, not as a fixed bunch of grit that's broken off. And hopefully, if we're lucky, we will eventually have a medical therapy for it. Now, in about 1 in 200 patients with BPPV in tertiary centres like ours, we can't get them better with multiple particle repositioning manoeuvres. So we discuss surgery, and it's very straightforward surgery for an otologist. It's almost an SHL operation, but that's possibly not quite fair. We do posterior canal plugging surgery, and Leicester, I tend to do about 3 a year. Done 35 so far, I think, which fits in the time I've been here. And that's a lot. You don't want to be doing large numbers because you should be getting the vast majority of patients better with other treatments. And very many of my patients come from outside the county. And of our patients, we've done 3 bilateral BPPV surgeries. And this is just an entertaining thing for when you get your consultant job. If I'm speaking mostly to registrars, you'll be out there on your own. So when I'd been a consultant for 2 or 3 years, I had a lovely lady who had intractable, dreadful bilateral BPPV. So I did one side, and she was much better. But she really wanted her second side doing. And I looked up the literature. There was nothing in the literature. So I phoned Richard Ramsden, who was our sort of president of ENT UK at the time. And I said, well, what do you think I should do? He said, well, I'd just cross your fingers and go ahead. Oh, okay, it's good science. And I phoned Joel Goebel, who's a professor in St. Louis in the States. And he said, Peter, I'll just say a prayer and go ahead. So I went ahead, and I'm not sure even now, just 15 years later, you'd be able to do that. And she had a wonderful, wonderful result. And she was able to cycle and do everything she wanted afterwards. So I've done 3 patients bilaterally, so it can be done. Now, the video is really beautiful. You'll see in a minute, I hope. It certainly played when we had a practice run a minute ago. And it really brings to life what BPPV is. So this is an axial section here. So all you do is a cortical mastoidectomy. There's your lateral semicircular canal, facial nerves pretty close by, but there's the posterior canal. Anyone going for the gold medal, you can just shout at your screen because I can't hear you. In fact, I can't see you, which is quite disconcerting. But shout at the screen. What's the diagnosis here? You got it. Large vestibular aqueduct syndrome. So this is actually a Taiwanese girl I put a cochlear implant into, but that's just by the by. This is just to show you the anatomy. So you come round the back of the posterior canal, the lateral canal rather. There's the posterior canal, and you open it up. So have a look at this. Now, there might be a slight lag before you get the video through because I'm having to use my phone to distribute this. But here's the lateral semicircular canal at the front, middle fossa dura up here, sigmoid sinus at the back down here. So I've drilled out the vertical posterior canal, and just look here. And see, there you are. Do you see that little tube in the middle there? Now, I know I've sucked a bit of perilymph there, but don't worry, she didn't have any hearing loss, I promise. And this is what the crystals go through. So the otoconia come up here, from the utricle round here, and they drop down here. So have a think about it when you're doing an Epley or a CMOT maneuver. You've got to get these crystals through this channel up here and then dump them back into the utricle. So you need quite a vicious shake sometimes to get that done. So there's BPPV, a real living condition. So we're going to move on to the second condition, which is Meniere's disease. You've seen this just a moment ago. And in fact, patients with Meniere's often have BPPV. So quite often I've done an endolymphatic sac decompression, because that sits here, and a posterior canal surgery at the same time. It's all in the same bit of clockwork. And here is an endoscopic view of the endolymphatic duct running into the petrous bone. So I do very, very few endolymphatic sac surgeries now because steroids are so effective. But when I did, I would tend to do them endoscopically and avulse the duct that goes in here. And obviously it's a narrow vestibular aqueduct here, whereas in large vestibular aqueduct syndrome here, it's a large one, it's a different condition. So The classification of Meniere's, and this is a classification you'll want to know for the exam, has changed. I'll put the paper down here for you, 2015. And helpfully, we now have probable or definite Meniere's disease. Before, you used to have possible, probable, definite, and certain. And certain required histological evidence, which wasn't terribly good because you had to be dead to give that. So they decided that wasn't such a great classification. So we have probable, but look at the symptoms here. Episodic vestibular symptoms of 20 minutes to 24 hours. That's pretty loose, eh? So that really has a big overlap with migraine. Fluctuating oral symptoms, again, big overlap with migraine. So you're not sure on this group, but it gives you permission to say, I am absolutely certain this is probable Meniere's disease. Strange concept, but it gives you this certainty of you're allowed to not know, and that's really important for some of these conditions. Whereas definite Meniere's disease is 2 or more vertigo attacks of 20 minutes to 12 hours. Meniere's isn't usually that much longer than that. With a documented low frequency sensory neural hearing loss, ideally fluctuating, and fluctuating tinnitus and fullness. So that's straightforward, if it's straightforward. But unfortunately, it can present just with fluctuating fullness or tinnitus or hearing loss, so sort of a cochlear hydrops, or it can present just with fluctuating vertigo attacks, which sound like migraine. That's vestibular hydrops. Excuse me. And then it can go on months or years later to produce all of the audiovestibular symptoms of Meniere. So it can be quite enigmatic. Your typical patient is in their 30s, 40s, 50s, but I've seen patients in their 80s and 90s, and down into childhood, but not very young childhood. Some are bilateral, sometimes that's autoimmune in origin. And ultimately, up to half of patients will get it in the opposite ear, which is an issue. And it affects, it's difficult, maybe 1 in 1,000, maybe more people than that. But again, another concept. I want you to think of Meniere's as 5 conditions in one. So you've got Meniere's disease, and 40% of Meniere's patients also have migraine. That makes it really challenging. 20% get BPPV as well, presumably because the labyrinth is damaged. Most will have a degree of unsteadiness and vestibulopathy, and most will have some degree of emotional response to it. So you have to address each of those subsections. And so never believe anyone who says there's nothing you can do for Meniere's disease. There's an enormous list of different things you can do. And we're going to look at 1 or 2 of them. We're going to look at medication. We're going to look at intratympanic steroids. You can do conservative treatment to start with, for sure. Grommet, Meniere, there's not a whole lot of evidence, but they certainly help some people. And the big surgical procedures of labyrinthectomy is a pretty brutal operation. And vestibular nerve section just are so rarely needed now. So let's think of these particular drugs. Beta-histine, so it's been a standard drug for the treatment of Meniere's for umpteen years. And many patients absolutely swear by it. You might want to give Stomatil for acute attacks, Cenarizine if they're going on holiday. Many people have had success with bendroflumetazide. I don't know, I'm not so keen, I don't use it very much. Maybe ladies who get their attacks before their periods, if it's not migraine, that might be helpful. Perimenstrual hydrops. And then urea, when I was Bill Gibson's fellow in Australia 18 years ago, they would all just pinch the nose and knock it back, and that was fine. Mixed with strong orange juice or something else because it tastes foul, it tastes of urine. I've never persuaded anyone in the UK to drink this stuff actually, but it is synthetic. But if you've got someone who's got a major exam or about to get married, if they drink the urea, they're not going to have an attack for 24 hours afterwards. That's fairly small print. So here's our favorite drug for Meniere's disease, beta-histine, 16 milligrams TDS, or even in a really high dose. So this is a great paper by Michael Strupp, BMJ 2016, worth quoting. Sorry, my mouse keeps moving things over. And you can see, with a high dose of beta-histine, fantastic. The high dose reduces, this is early on, this is later on, greatly reduces the number of attacks down the line. Even better, a low dose reduces the number of attacks down the line. And so does placebo. So, although we have a highly significant reduction in attacks on any of those three treatments. And we can pat ourselves on the back for getting our patient better for giving them beta-histine. There's no difference between placebo and treatment. So then you've got this dilemma. Is it ethical to treat them with beta-histine? I tell them about the BMJ article, and I say there are other papers showing it's a vestibular sedative, and some people seem to swear by it. So maybe there are lots of different subtypes of Meniere's disease, and maybe that's why some people benefit and others don't. So it's probably ethical to give it. Intratympanic steroids have been the mainstay of treatment now for a number of years, and there's two researched outcomes I'd like to share with you. The first is a drug called OTO-104. It's not commercially available. I think I'm on my 5th study with them, and many of you may have been in departments which also trialed this drug. And what it is, it's a gel which is liquid when it's on ice, and then unusually it becomes a gel when it warms up in the middle ear. It's a sort of toothpaste actually with dexamethasone in it essentially. And you can see when you inject dexamethasone into an ear, it peaks in concentration in the cochlea, albeit 300 times higher than if you inject it into a vein, but after 2 hours it peaks and then goes out. But if you give the OTO-104, it lasts for weeks or months after injection. So we started this with great excitement and great hope. And look, fantastic. The reduction in vertigo attacks, huge reduction in vertigo attacks with the bigger concentrations. Well, not quite, because it doesn't reach significance. So they missed that endpoint, which was a shame. It helped tinnitus, and again, just missed the endpoint. So they announced their results. Now, if you look at this, if you imagine this is the number of attacks, and then after treatment, the number of attacks, absolutely fantastic. But sadly, that's not the case. This is the autonomy share price after they released their results. So it didn't work. Now, to be fair to them, I think part of this was due to the structure of the research, that I think a lot of migraine patients were probably included in those early trials. So they're doing another study at the moment, recruiting absolutely pure unilateral Meniere's disease. And if it does work, it'll be fantastic, because the drug is very easy to give. It's given under local anesthetic, just on a couch, and a patient can get up and go home straight away afterwards. So we're still recruiting for that study. And then we come on to a totally different treatment, different drug, totally different outcome. And this is solumedrone, methylprednisolone. And again, put a blob of local anesthetic on the ear, inject the drug in, a couple of weeks apart. And this study was funded by the Meniere Society. Just under £300,000 of patients' own money funded this study. It was set up by Adolfo Bronstein, Johnny Harcourt and his colleagues at Imperial and Charing Cross, and my team joined in at the end just to get numbers up. Now, these are actually my wife's hands, believe it or not. She's pretending to inject the cream into this good lady who's my mother-in-law, who actually needed steroid injections. And this is my otology fellow, who's an absolutely wonderful neurotologist, Yogan Saman. And he's injecting steroid into my mother-in-law's ear for acute sensory neural hearing loss. But that's all it takes. You just inject the drug through the ear. She's even smiling, which is very kind of her, although it can be a bit sore, this drug. And if we look at the results, and this is the highest quality study I've ever been involved in, and we published it in the Lancet. Here we are, there's the reference for you there. With both solumedrone or gentamicin, both groups, we had a 90% reduction in vertigo attacks over 2 years, with fewer side effects in the steroid group. And that, given a natural resolution rate probably of about 70%, that's still a highly significant finding. And Johnny Harcourt followed up the study at 5 years and found an average 95% reduction in vertigo. That's pretty impressive. It's one study. Always be careful. Maybe we got lucky with the patient group, but to me, that's impressive. And it's the standard treatment that I use. And it's essentially as close as you can get a risk-free treatment. And you compare that to gentamicin, where there's a 5% loss, a risk of total loss of hearing, and also of unsteadiness with the treatment. But I'll still use gentamicin for intractable disease. And if you look at the data, which I hope is coming up reasonably quickly on your screens, and you've got steroids being the black line, gentamicin being the white line. These are the number of attacks of vertigo in 6 months before, falling from about 20 down to 1 or 2, and in a month before, falling down from about 6 to almost nothing. So dramatic responses. Likewise, if I can get the right, sorry, if I can get the right slide, there we are. So vertigo symptom scales. Now, why is this doing it? I've got a very sensitive mouse here. And tinnitus handicap, oral fullness, all of them came down dramatically in both the steroid and the gentamicin groups. And even though it was a bit sore, that's my wife there with my mother-in-law, and we are still friends, I'm glad to say. Sorry about the colours, aren't very good on that one, are they? There we are. Okay, and we've also got another £100,000 from the wonderful Meniere Society, and we're launching a Meniere's registry. It'll be with Louisa Murden at Guy's, with Johnny Harcourt, Chancross, me in Leicester, and John Phillips in Norwich, which we'll start off with. So we want to answer lots of difficult questions, such as how likely am I to get bilateral disease? And we're going to try and enroll as many Meniere's patients in the UK ultimately as we can, but these are expensive things to do. So finally, if you're still with me, we're going to move on to the rather further, should I say, enigmatic condition of PPPD, persistent postural-perceptual dizziness. We recommend you call it PPPD rather than PPPD, because that sounds too much like BPPV, and we get into this sort of alphabet spaghetti, and patients get completely confused. Now, you've got to remember, this is a new diagnosis. It's a man-made diagnosis in 2016, but it's really helpful. Getting back to absolute basics, for those of you just beginning your training, we've got a number of things that contribute to balance. You've got your visual input, your vestibular input, and your proprioceptive input, which is all processed in the brain. And the problem is in here. So you might think of it as a software problem processing the information. And I often tell patients it's a bit like if you play golf or tennis and you get a slice, it's incredibly difficult to get rid of that slice. Now, patients talk about muscle memory. Of course, it's nothing to do with that. It's how the printed circuit board is laid down in your brain. And if you are, I don't know, Tiger Woods, you have a fabulously stable printed circuit board. And if you're like most ENT surgeons trying to play golf, you clearly have a few loose connections. So how do we assess for this condition? Well, we use things like computerized dynamic posturography. So this is one of those contraptions where the floor moves and the walls move in different paradigms, which take apart the proprioceptive vision and vestibular inputs to balance. And you can actually see the printed output out here. And that gives us an idea of which element is not working. And again, if flashing lights are not good for you, if you just look away for the next slide. Or we can use, this is the vertex posturography. So you can see here, we're following an aeroplane. So if you're visually dominant, it can be challenging for you. And as you move, the wall is moving with you here. And again, this is the long-suffering Liz, who I had tied into the TRV chair previously. And then the other one you can have is this chap here. And again, I'm not sure, to me, it's absolutely beautifully crystal clear. I'm not sure how it'll be coming out on your screens because this is all coming over my mobile phone. But you can have this optokinetic stimulation. Is that showing, Reshma, or?
It's working fine.
It is super. Oh, good. I'm glad to hear that. Okay, so we can stimulate lots of different parts of the balance system. So PPPD. There are lots of old diagnoses such as chronic subjective vertigo, visual vertigo, phobic postural dizziness, spatial motion discomfort, psychogenic agents, lots of different things. And we wrap them all up now in this condition called PPPD. And here are the symptoms of PPPD. Non-spinning vertigo, I feel like I'm on a boat, unsteadiness, I feel like I fall. They're all heart sync, aren't they? You think, oh, this could be anything. And this isn't a bin, a diagnostic bin, be really clear. This is a specific diagnosis. So you want your patient to struggle in motional crowds or pattern floors, but to be better lying still or sitting down, for example. And they get this hypervigilance, visual hypersensitivity. And it's common after vestibular insult. So you've had a vestibular neuronitis, BPPV, a bang on the head. And it's more common in those who have a history of migraine, generalized anxiety, and panic attacks. Now, this is a bit of a busy slide. This is the Barani Society diagnostic criteria. I'm not going to go through that all with you, but the bottom line is you need to have had it for most days for at least 3 months before you can establish that diagnosis. So this is a long-term condition, and it needs to cause significant distress or functional impairment. And these are really difficult patients to manage. And I get very large numbers of patients sent to me because people have given up with management on them, but you don't need to. And there are some good papers out there. There's one in Practical Neurology, that's a sort of BMJ journal. If you Google it, you'll get the papers up very easily. So why does it happen? Well, this is a few years ago. This is me with younger son and older son, and this is Machu Picchu, or this is the Inca Trail, and it really is a very, very long way down behind here. Now, if I go and stand up on this edge, I'm visually dominant, I will be absolutely terrified. I stiffen up, I start sweating, I'll start shaking, I'll step backwards. If there were walls to put my back to, I would do that. If there was furniture to hold on to, I would hold on. So what did my two boys do here above the 2,000-foot drop? Yeah, they jumped up there and they jumped to the edge saying, look, Dad, this is easy. Because they are vestibular dominant and the long fall doesn't trouble them at all. So that's one of the issues here. So when you get this, you stiffen, you get anxious. And this is a higher cortical response. So the good news is we can treat it. If you just give them vestibular physiotherapy, actually, you're going to get a fair number of these people better. But there are other things we can do as well with medication and psychological support. So having explained it, I always talk to them about the 3 pillars of treatment. And the first paper I published on this was in a highly esteemed medical journal, the Daily Mail. Well, there we are. Anyway, it got a lot of interest, and actually it's helped a lot of patients. So vestibular physiotherapy, CBT or anxiety management books, and then medication. You can use an SSRI like citalopram or sertraline, they're pretty good at this. Or the poster child, if you like, medication is venlafaxine. And venlafaxine is really great because it has a good anti-anxiety component, but it affects serotonin in the vestibular nuclei, which somehow seems to reduce the symptoms of PPPD. It's having several effects. But you start at a really low dose, 37.5 milligrams, even cutting the smallest capsule in half. Tell the patient it'll take 2 or 3 weeks to get through it, the initial sort of difficulties, and then gradually build it up. And they take the medicine for 12 months. Now, with that and physiotherapy, you're looking at about 80% of your patients getting better or significantly better. So it's a really good thing to do. But you do need to take them through the side effects of SSRIs and SNRIs, which include some difficulty coming off the drug at the end. Now, personally, I get the GP to prescribe them because they know more of the medical history. I don't prescribe them myself. I recommend them to the GP, and I think that's the right thing to do. So there you are. There's three conditions for you. You've got BPPV, Menieres, and PPPD. There's a whole bunch of other stuff we could talk about if we wanted to, but we're not going to. And if anyone is around and wants to ask any questions, you're welcome to. Reshma.
Thank you so much. That was an absolutely brilliant talk and an update on obviously 3 very important conditions for the ENT surgeon. So we've got a couple of questions. So the first one was, how does a Grommet insertion help in Meniere's disease?
Well, that's an assumption. That's a leap of faith. We don't know that it does, because there's not really any papers out there saying that it definitely does. Do I use it? Yeah, I do. And there's 3 indications rather, sorry, for Grommet insertion in Meniere's disease. The first is to help with intratympanic injections. So some patients like the Grommet in there. So if they're needing regular injections, so for example, autoimmune inner ear disease causing Meniere's type symptoms, if you have a Grommet in there, you can inject through the drum and it's less painful. So that's the first thing. The second thing is that somehow so just before I come on the main thing, sorry. The second thing is you can use it for the Meniere device, which is that pressure equaling device. And again, that shows a trend towards improvement. If you put the Meniere in, we're not sure. But the main reason is it equalizes pressure over the tympanic membrane. Now, we think there are probably pressure receptors around the round window niche, we know that Meniere's patients and migraine patients are both sensitive to pressure change and environmental change. And somehow the assumption is that by putting a grommet in, you don't get the big fluctuations in middle ear pressure. You stabilize the pressure changes, i.e. throughout the labyrinth and cochlea, or against those pressure receptors around the round window niche. And somehow that reduces the drive for Meniere's. But remember that 70% of Meniere's patients are going to get better on whatever you give them. So be very careful in making an assumption that because you put a grommet in, they get better. But having said that, I have a fair number of patients who have oral fullness as a major part of their Meniere syndrome. They're immensely relieved by the grommet. And a year later when it blocks, they're straight back on the phone and they know when it blocks. So that's as close as I can get to an answer.
Thank you. So can I just check, so sometimes you'll put in a grommet on its own without steroids, or would you do them?
For sure, yeah. But generally what I do, because steroids are, it's just, how many treatments have we got in medicine which are effectively zero risk? They're as close to zero risk as you can get, which are so incredibly effective. So what I tend to do is if I'm going to go to the effort of putting a grommet in, I put some steroid in at the same time anyway, and maybe put a second dose 2 weeks later. Yeah.
Okay. Pardon my ignorance because I don't know what a Silverstein wick is.
Okay, so yeah, Silverstein wick I used to use a lot. It's a long time since I used one. Silverstein's an American otologist. What it is it's quite a large blue grommet with a wide lumen, and then you get this micro wick, like a tiny poke wick, and you do a myringotomy over the round window niche, so a posterior myringotomy. You put this rather soft blue grommet in, which is quite fiddly to get in actually, and then you have to get a pair of fine crocks and you use the micro wick and you thread it through the center of the grommet, so it goes from the outside of the drum and theoretically into the round window niche. Now you get a spot of blood or fluid on it, it swells up immediately and you can't get the blimmin' thing in, so it's annoying. So they give you 2 of them, so you've got 2 chances to get it in. And then the idea is you then put steroid eardrops into your ear canal, which soak through the wick into the middle ear. And you know, before intratympanic steroids, we used to do this quite a lot, and I did it a lot actually, but I'm very unconvinced as to the dose of steroid we got into the inner ear. So I don't do it at all now, and I purely use intratympanic injections because I'm very comfortable that they work.
But isn't there like uncertainty about the concentration of steroid dose in the middle ear present when you do a normal injection?
Yeah, but yeah, you know, you're absolutely right there. But you're much more certain than you are when you use a wick. When you use a wick, you have no idea how much is going in there. When you use solumedrone, I use 62.5 milligrams per mil, and I inject about 0.4 mils. Now, half of that's going to squirt out. So normally when you inject, you get the patient to swallow as you inject, then lie on their side for half an hour. And I normally get them to spit onto a tissue for half an hour. So by spitting, they're not swallowing the drug down. And again, the concentration of solumedrone will peak at about 2 or 3 hours. So you're going to get this massive pulse of steroid into the inner ear. I can't tell you how much goes in there. There have been studies looking at it in guinea pigs and so on. But we don't know exactly how much goes in there. But just as an adjunct to that, during the COVID period, I've stopped everyone spitting. So I just get them to swallow, because I don't want people spitting in the clinic room and creating aerosol. So, and again, you know, what you're seeing may be distressing to you, but we don't know the answer to so many of these things. And we've got, goodness knows how many research projects going on around a large number of these issues at the moment. And a lot of what we do in medicine is not evidence-based. So actually having the Lancet paper for intratympanic steroids is one of the very few studies, really high quality studies we have to support treatment in ENT. You know, so we're very fortunate to have that. And many of the other things we do, we can't juggle all the different parameters. So to get 60 patients into the Lancet paper study who are pure Meniere's, we reviewed 1,000 patients who said they had Meniere's disease to get the 60 purest, and took 5 years recruiting them. Now, you can then say, well, okay, well, how about getting them to spit or not spit or have a... You can't do it. That's not possible. So, you know, during your consultant life, you just have to be pragmatic and say, well, that's probably right. And some of the things you'll look back on at the end of your career and you'll go, what the hell was I doing? It doesn't make sense. And others you'll think, I always remember, just as an example, Bill Gibson, who was my great mentor in Australia, every time he did an EPLI, he would shake the patient like this. And I would always go, must be a bit past it. Why is he doing that? So I sort of started doing it after a year or two. Of course I do on everyone now, because it's brilliant. It works. You shake those crystals out because they're real crystals, which is why I showed you that video of the endolymphatic duct. So some things you do where you think they work, then there are papers published later which show they work, and others not.
Mm-hmm. Okay, thank you. I'm just going to carry on with the questions for the Meniere's disease.
Yeah.
How long can you give beta-histine for?
Ever.
Okay.
Yeah, as long as your GP will pay for it, and as long as you feel giving a drug that doesn't work. The thing is, I mean, look, it's a safe drug, and it probably is a vestibular sedative. And you can start at 16 milligrams TDS. I used to go up to 32 milligrams TDS, which is fine. It's incredibly well tolerated. There are papers out there giving much higher doses than that as well. Occasionally, it causes a little bit of nausea. Very, very rarely you get patients having sort of skin reactions to it, incredibly rarely. But it's incredibly well tolerated. And there are, as I said, some patients who absolutely swear by it. They miss one of their tablets and they get symptoms. Now, whether that's placebo or not, I don't know. But actually, the study we're doing with the Meniere's registry, which we're going to get in very many hundreds of patients, we're pretty sure there are lots of subgroups of Meniere's disease. So I'm also leading on the Meniere's project on the 100,000 genome project. And we're looking at the whole genome of patients with Meniere's disease and family links. And I'm sure there's going to be lots of different subtypes. And it's probably I think it's probably a multifactorial disease. And the endolymphatic hydrops is just the final common denominator. And because of that, you'd expect different drugs to work on different people. So again, just because the BMJ paper didn't show beta-histine doesn't work, doesn't mean it doesn't for some people.
Okay. Do you perform vestibular function tests prior to intratympanic drugs, gentamicin or steroids? That's
a really good question. And that's a question I always ask on the Leicester Balance course when I've got my panel there. And if you have Richard Irving, who we all know well, he'll go, no, I don't do anything. I just treat them, slightly sort of provocatively. Here's the simple answer. Before intratympanic steroids, the only test you must do is a hearing test. However, if you are uncertain whether you're going to get steroids or gentamicin or other forms of therapy, I genuinely would, I definitely get a caloric test, because what you can have active Meniere's disease on one side, and you can have a vestibular Meniere's on the other, where you've got a vestibular deficit on the opposite ear. And you don't want to go and put gentamicin into an ear when there's no function on the other ear. Now, the other comment I have is you saw my description of Meniere's being 5 conditions in one. And because a lot of patients come to me for second, third, fourth opinions, who have often had the disease for a long time, they're a bit imbalanced, etc., I often do a full battery of balance tests. And I think early in the disease, you don't need to. But later on in the disease, where they've got some vestibulopathy, you're not sure which ear it is, then it's helpful to do that. And just to complicate things, you know that if you have an under-functioning ear, say from burnt out Meniere's disease, when you do VNG testing, the fast phase of the nystagmus will be to the opposite ear. Just to complicate it, if they've got active Meniere's disease, it'll beat to the affected ear. So that's just a subtlety of testing, which can tell you which ear is active if you're not sure what's going on. So yeah, I tend to do balance testing on them if they've had it for a while. If it's straightforward Meniere's disease, just with obvious fluctuating hearing loss, and I'm going to give them steroids, there's no need to do balance testing. But you need to do an MRI scan because there is an incidence of acoustic neuroma with Meniere's. And actually, a small number of acoustics I've given gentamicin to stop their Meniere symptoms. But it may or may not be of any interest, and this is completely anecdotal. The number of acoustic neuromas I've diagnosed in Meniere's disease is equal in the affected ear and the contralateral ear, and you can read into that what you like.
Okay, thank you. So could you just say again your intratympanic steroid regime for Meniere's?
Okay, so I put I discuss with the patient. I think this is actually these are good questions. So I discuss at a clinic appointment with the patient. I then give them the reference from the Lancet paper, and I ask them to go, because that's on free access. I have fairly clever patients, I know you're smiling. If I think it's appropriate, I give them the Lancet paper reference. Go and read that. I tell them the risks and benefits of gentamicin versus steroids and the other thing. The trouble is, when you do a lot of medical legal reporting, you sort of get more cautious. And then they come back whenever. And I do a written consent for it now. I never used to. I put EMLA on the cream, a little tiny blob of EMLA cream on the drum, but don't use a spatula or something to put it on. Use one of those injecty things, you know, where you've got a syringe and the sort of inject a bit at the end. Put a tiny bleb on the posterior inferior part of the drum. Leave them for 10 or 15 minutes. It numbs the drum, but it also softens it. I then use an orange spinal needle and a 2 ml syringe. I mix up the solumedrone to a concentration of 62.5 milligrams a mil, bend the needle a little bit, and then under the microscope, just very slowly inject 0.2 mils. I get them to swallow, 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 take the needle out, a little bit of drug will squirt back, and you can usually see the meniscus rising in the middle ear. And then I go in again, and I put another 0.1, 0.2 mils in. And then I get them to lie on their side with the affected ear up for 20 to 30 minutes, spitting if it's not COVID, not spitting if it's the COVID era. Mm-hmm. And then I repeat it 2 weeks later. Now, you need to warn them that it can be sore, and you'll have a few patients who are very, very sore, but really reassure them that it'll absolutely go within 2 hours. It's not doing them any harm at all. And if they're worried about the pain, I just get them to take a paracetamol or a Brufen an hour before treatment, and I inject 0.1 mil less at the second injection.
Mm-hmm. And you injected the anterior inferior quadrant, is that what you said?
The posterior inferior. But if you go into the anterior inferior, it probably makes more sense.
It's just because I find that when I go any lower, it just keeps
squirts back out. Yeah. So I think it's a perfectly rational statement you're making, and it's probably more sensible to go at the front. And some people also put a second hole in to release the pressure. You can do that. I don't do that because it just seems to hurt again for me. But you see, the thing is that because I'm getting them to lie at 45 degrees, actually with the meniscus effect, that there's enough drug covering the over window and the round window. And the bottom line is, it works.
Okay, fantastic. So just seeing if there's any other questions for Meniere's. When do you decide that a patient with Meniere's needs surgery?
Well, it depends that's a good question. Depends what you mean by surgery. So my practice has certainly changed. So I will start with a low salt diet, 2.5 grams of salt a day. If they want to try a diuretic, fine, but I don't use it that often. If they want to try beta-histine, that's fine as well. And if they just want explanation and we'll count up how many attacks they have, that's fine. But I go into intratympanic steroids very, very early, and it's essentially my first line treatment. I mean, I see no point. If you've got results that are this good for the treatment that's essentially risk-free, why not just do it? Now, if you fail intratympanic steroids, I will offer a top-up dose when they fail, and there's some evidence that the top-up doses are even more effective. And some patients will need several injections, and those with autoimmune inner ear disease, bilateral, may need multiple injections because it only may last for a few months for them. It brings the hearing up dramatically, then it drops down. Now, in the 10 or 15% of patients who don't seem to respond well to steroids, then I think that's where this question is coming in. So then you start thinking about surgery for those patients who don't respond to medication, don't respond to intratympanic steroids, and who are very distressed. Now, paradoxically, the next most conservative treatment after intratympanic steroids is endolymphatic sac surgery. It's a really straightforward surgery. You do a cortical mastoidectomy. As long as you know your anatomy, you drill out below the posterior canal and lateral canal, and the endolymphatic sac lies at a 45-degree angle roughly going in there. And when I don't know if you still do drilling for the fellowship exams, but that was my question in the fellowship exam. So I had to convert a cortical mastoidectomy into a combined approach to tympanoplasty, and I whizzed through that, and then they got me to do an endolymphatic sac decompression in the exam or something like that. So you know roughly where it is, but it can lie in a big arc, But it's a pretty low risk procedure. And if you look at Bill Gibson's data, 80% of patients have a reduction in vertigo and 50% never have another attack. And you shouldn't really be having complications, but it's the surgery. Then if you go up to the next level of risk, it's intratympanic gentamicin. Now, gentamicin is the gold standard, fabulous treatment for Meniere's disease. And I historically would put 3 injections in, but I'm again much more conservative. I use 40 milligrams a mil, inject exactly the same way as the steroid. And I put 1 injection in and see what happens. And if they have a severe hearing loss, and there's a 5% risk. If they're severely dizzy for weeks, they get severe tinnitus, I don't put a second injection in. If nothing happens, I put a second injection in, and then I wait. And you can titrate it, you see. So you wait, then they have another attack. If they do a few months later, put a 3rd injection in. And 2 to 3 is the typical number that you can use. But I've got 2 or 3 patients, I've actually put 7 in over a period of a year or 2 to try and ablate the vestibular function. Now, if you look at the literature, and there are quite a few good meta-analyses out there, we're talking about 98% of patients have a reduction in vertigo, and 80% never have another attack with gentamicin. But about 5% of people lose all the hearing in a treated ear. And a few patients are very, very dizzy for weeks or even months after. So be pretty cautious in the elderly with gentamicin, because it can knock them off their feet. But it is, and in our study, we didn't have any hearing loss or complications because we were quite conservative with gentamicin, and we did 30 patients. So that's a great treatment. Endolymphatic sac treatment we've talked about. Then if you go on to the next block, it's labyrinthectomy, which is, as I say, it's a brutal operation, and your patients really do not like labyrinthectomy. So I've done a handful of those. And then you've got vestibular nerve section. Now, vestibular nerve section is an interesting one in that I don't do it because I don't work in a neurosurgical unit. But for someone, say, who is a musician or has, I don't know, an only hearing ear or something, then that's something. I mean, you probably wouldn't do it in only hearing ear, but someone whose hearing is very, very valuable to them. You might start thinking about vestibular nerve section as a possible thing. It's not, even that's not 100% successful. And I haven't had to refer anyone for vestibular nerve section for as long as I can remember. I'm not sure. I'm not actually sure I've referred anyone for vestibular nerve section in the 16 years I've been in Leicester, because gentamicin, sac surgery, or steroids have ultimately got everyone better.
That's good for everyone.
Yeah.
Okay, so that was the last of our Meniere's questions. Now I'll move on to the BPPV ones. Do you suggest screening for osteoporosis for recurrent BPPV?
It's not our job. No, I mean, it's a good question. I'm glad the question is being asked, because this is really what I'm trying to get across. I mean, these patients should be being screened for osteoporosis anyway, because they're in that category. They're in their 70s, 80s, and so on. But I don't refer them on for that. Some people do. I do take vitamin D sometimes on patients, but more often patients with chronic imbalance, and particularly in Leicester, as you may have seen on the news, we have a fairly high ethnic population here, and a lot of the ladies in particular are pretty housebound. All they do is cooking and cleaning and so on, and they're not out of the house a lot. And we know that from speaking to their families. And they have a very high risk of vitamin D deficiency. And they often present with chronic imbalance. But I mean, there's a whole lot of psychosocial stuff there as well. But I'll take their vitamin D levels. For BPPV, you can do that. And if it's severe, that may be what's causing it. But I just give everyone vitamin D, anyone. Anyway, so I say take 4,000 units a day for a month, followed by 1,000 units a day over the winter months. And it seems to be a sensible thing to do. And I think that it's a fair question, screening for osteoporosis, but I think it's too far outside what we do. And if papers come about, that's fine. But when you're getting into that group of elderly patients who are frail, who are at risk of falling or are falling, who've got BPPV, what you really want to do is refer them to the Falls Clinic. And they will do the osteoporosis screening for you, along with getting OT assessment at home, muscle strengthening exercises, and medical review.
Okay, fantastic. And what's your criteria for choosing to operate on intractable BPPV?
Oh, it's very easy. They have to come into the clinic room on their knees begging, essentially. So I'm really conservative. I have lots of people referred to me for it. And I think, as a good physician, you want to do medical for everyone. So it's 1 in 200, as I said, I operate on. It's essentially the patient whose life is severely affected by their BPPV, be it unilateral or bilateral, and who is well enough to sustain surgery and is willing to take the risk. So in my series of 35, there's a series from North America and a series from Hamagi and Pole in, I think in Sydney. I think all three have got a dead ear rate of about 3%. So I've had 1 out of 35. I was incredibly upset about it. But the patient's been dizzy-free. She's a senior executive and she's got her life back. And it was early on, so I don't know. But I haven't had any for over 10 years, any dead ears over 10 years. So as long as patients are aware of that. But you see, the indications can be quite variable. So the youngest patient I've done is 28, and she is an accountant. And whenever she looked down at the desk, just that, every time she did it, she got this brief disequilibrium. And that was enough for her to have BPPV surgery, because no matter how many times we did Epi and Simon, Brandara and vitamin D over several years, she just kept relapsing. And it's changed her life. It's been fantastic. And I've got, at the other extreme, my oldest patient is 88, and she was quite frail and unsteady. And she said, Professor, if you don't do the operation, I'm going to jump out the window of my home. Now that's never an encouraging, yeah, I know, never an encouraging start, but she was sort of saying something to me, and I did her, and I cured her BPPV, but I don't think I lifted her mood very much. So you've got to be really careful choosing. And I think that in this type of surgery, quality of life surgery, what's really important is you need to get an absolute bond with your patient. So this is where all of your clinician skills come in. Really great eye contact. Of course, I'm staring at you on the corner of the screen rather than looking over here. It was just natural, isn't it? So really good eye contact. And, you know, touch as well. You're touching your patient's shoulder, doing it all professionally and properly, and seeing them many times. So the average length of time for BPPV in the series we published, I think was 10 years, was the average length. But it ranged from 2 years to 30 years. It's very variable. And I don't know if any of you got relatives with BPPV, but it's not just short spins when you lie down. It's your whole life is taken over by it. Patients feel sick when they're walking and turning their head. It's just there the whole time. It's absolutely awful for patients. And then you get them better, bang, suddenly it's kind of a miracle.
Yeah, my mum had it last week, and for the first time I was able to help her with something.
Hey, golden child.
That leads me to Mr. Einan Lewis's question, which I'll ask on his behalf.
I think I'm honoured you're listening.
Yeah. Let me see. Okay, so he says, what are your views of cervicogenic vertigo? And I'll see if I can unmute him in the meantime.
Okay, yeah, no, that's a really good question, and it's a challenging one. I mean, I think the bottom line is yes, it exists, obviously it's a medical legal minefield, and it's a difficult one. But the way to do it is you can actually do VNG for it as well. So when we do normal VNG, we do this. So we get them to turn the head side to side. Or when you do a clinical examination, you might do a head thrust like that. But what you do, if you get the head still and then rotate the body on a still head, I can't do it in this chair here, but it looks ridiculous, doesn't it? But you know what I mean? If you hold the head and then you rotate the body either side, if that induces dizziness, that's a cervicogenic cause because you're not stimulating the labyrinth. I can hear you, Nick. Very badly.
I'll get back to you in a second. Yeah, sorry, just talking to my wife there.
Sorry, I'm glad we weren't interrupting anything there.
No, I'm sorry about that, Pete. It was a question that came up recently.
Yeah.
I was very interested to hear your views on this kind of controversial subject. I was talking to other neurologists about it.
Yes. Oh, well, I mean, I'll restart. So, yes, I absolutely believe it exists. You know, elderly patients have very stiff necks and so on. There are proprioceptors in the cervical spine that feed into the vestibular nuclei. And, you know, many people say, when I turn my head, I'm acutely dizzy. You can discuss, you know, vascular causes and so on. You can discuss pain as a cause. But as I was saying when you were talking to your wife, if you hold your patient's head still and you rotate their body, but with the head still, and you stimulate dizziness, that's going to be cervicogenic in origin. The problem with cervicogenic and why it's become controversial is twofold. Firstly, whiplash injury and medical legal claims. And secondly, vestibulopathy induces occipital neck ache. So almost all of our patients, as you well know, but all of our patients with balance disorder complain of occipital neck ache. So that's a classical symptom of a chronic balance disorder because they tense themselves up like this. And they say, it's my neck, doc, what's causing my dizziness. But it's not, it's the dizziness that's causing their neck pain. So cervicogenic dizziness certainly can be overdiagnosed. But following whiplash injury and in elderly patients, there will undoubtedly be a contribution from the cervicogenic proprioceptors.
Do you think there can be any sort of vascular component to that, or aberrant?
Yeah, I think that's a fair question. Now, you've got there are two elements there. That if you've got a very elderly patient who's crumbling away in front of your eyes, and you do an MRI scan, and you've got lots of little white dots over the brain. So Adolfo Bronstein at Imperial's done a nice paper on that, and showing the greater number of white dots on the MRI scan, the greater the imbalance the patient experiences. So that's an indirect relation to vascular. But if you're asking, might there be vascular compression, in other words, VBI or some similar condition, you have to be really careful. So if we look at VBI, vertebral insufficiency, which is more on neck extension, of course, it's actually usually BPPV, but if it's on neck extension and they're getting a genuine vascular compromise, you're closing off the vascular circulation to the posterior cranial fossa. So you're going to get alteration in consciousness, speech, and a whole range of things. So that's pretty dramatic. Now, the second thing, which is a really important one, I think, for the registrars listening, is if you have a younger patient who's had a whiplash injury, or even hyperextending their neck at the hairdressers, we've had people, they can get carotid artery dissections. So be really cautious of someone who's had a whiplash injury who comes in fairly acutely with dizziness, and just think about carotid dissection as a possibility. I'll be honest, I've seen, when I was a neurosurgical SHO in Bristol a long time ago, I saw a couple of cases of that. So I suppose it's fixed in my mind. Have I seen it as a consultant? I haven't, but maybe they don't come to me, they come to the neurologists. Okay,
thanks. And thanks for a brilliant lecture as well. It's really, really interesting stuff. Yeah, thank you.
Okay, questions about triple PD now.
Yeah, I'm really impressed, guys. I thought you'd be straight off for a beer or a gin, anyone who'd managed to survive an hour of balance on a Monday evening.
No, they're all still here.
Very impressed.
Okay, so is triple PD more a psychosomatic condition exacerbated by anxiety, particularly if it responds to anxiolytics?
Okay. I have to put my best political correctness hat on here, because I have to be very careful. Now, if you the very famous paper that I did with Linda Luxon on this in the Daily Mail, I actually didn't know she was the other author on the paper, but she would basically say, just get them to go and see a psychiatrist. Now, I have a slightly different view in that, we have my colleagues at the university have a $2 million grant, which they've been spectacularly successful in getting. And we're going to look at a lot of these central processing disorders. There is undoubtedly an anxiety, emotional component to this. But I think there's also a hypervigilance that develops in the vestibular system. And if it's not a word you're using clinically, I really urge you to sort of get this one on the tip of your tongue. So hypervigilance is a brilliant, brilliant word. Whether you're talking about tinnitus, many symptoms, bodily symptoms, and also dizziness. So these patients are much more visually sensitive, much more motion sensitive. Now, for sure, they may be anxious driving that sensitivity, but that sensitivity also drives anxiety, and it's difficult actually to unpick them. So I don't want this to be thought of as a purely psychological disorder, but it then depends what you define a psychological disorder as. So the term I use for my patients is that this is a software disorder. So the way I mean, I'll give you the stuff that I say to the patient. So what I'll say to them is, you have a printed circuit board in your brain, which makes you move your muscles in this coordination. And when you have a vestibular injury, some of those little wires on the printed circuit board get knocked off onto the wrong bit and they short circuit. And then I say, as humans, the way we repair neurological problems is by repetition. So if you're a child, you get mama, mama, mama. And if you get a slice in golf, your coach gets you to hit the ball 1,000 times so you overcome it. And it's exactly the same with this. So we're going to do repetitive exercises to get the printed circuit board wires getting back in alignment. So that's part of it. So there is a sort of a neurological part to it. But we also absolutely plainly know there's a very significant emotional anxiety element to it. And we're then into the realms of sort of neuropsychiatry, is what is psychological and what is neurological. And, you know, it's on that boundary, isn't it?
Mm-hmm, mm-hmm. Thank you. Thank you for being very diplomatic with that explanation as well. Okay, is there a chance of some proportion of PPPD being otic capsule dehiscence syndromes? What's your experience been?
Shouldn't be, no. No, I mean, they're quite separate. And you should be able to diagnose an otic capsule dehiscence syndrome. That's a quite grand word, but I'm presuming you're meaning superior canal dehiscence or lateral canal fistula, that sort of condition. No, they're completely different. So those conditions are labyrinthine in origin, and so if you want to test, they're episodic. If you want to test for them, do Valsalva, put a tuning fork on the ankle, do tympanometry and VNG at the same time, do scans, do VEMPs, and you'll get a positive result, hopefully, on some of those tests. Whereas PPPD is a clinical diagnosis, and in fact, interestingly, one of the hallmarks of many patients with PPPD is they have normal posturography. So they have very vestibular symptoms, but you do the computerized dynamic posturography that I showed you, and it's normal. And so it's the way their brain is interpreting signals that is coming to it that makes it difficult and challenging for them.
Okay, great, thank you. So I'm going to ask you a topical question, which is obviously going to be about COVID and moving forward with virtual clinics and telephone clinics. How are you providing your balance services? And can you advise us on...
Okay, so I can give you a lot of stuff hot off the press if you've got 1 minute. I'm giving a lecture on this on Thursday at lunchtime. I think Oticon are sponsoring it. And then big plug, Royal Society of Medicine BSO lectures, which there was a brilliant one last week. There's one tomorrow that Chris Aldrin's running on an international group of surgeons, which everyone should be watching. And I'm running the one next Tuesday at the RSM it's in the evening sometime, I can't remember what time it is. I think it's 6 till 7:30. And I've got a fantastic group of speakers from various places on how we are running clinics. We're doing a lecture with Louisa Murden from London on how to do virtual clinics and all of the other stuff. Now, the other thing, just before I come to answer your question, is I've had a very interesting few months because NHS England asked me to comment on their proposals for changing what we can do in balance clinics and audiology clinics. And that was on May the 9th, I wrote it. And they haven't answered, we've emailed them. And we eventually, last week, I got together with a group of audiological associations. And we wrote to some of the junior health ministers. And then over the weekend, Shak Saeed, Tony Narula, and Nirmal Kumar and I, we wrote a letter to Jeremy Hunt and Matt Hancock. And we got a response today. So they've asked me to revise the guidelines. That's fantastic. So I've revised the guidelines today. I've submitted them back to NHS England. I don't want to overstate what I'm doing, be absolutely clear here. But the otology bit for what our services can offer, they have accepted that they should have had this out earlier. The world's gone on, we've changed what we can do. And I'm really hoping that will be republished later this year. Because at the moment, we have a partial stop. And partial stop means you can only do emergency face-to-face stuff. No balance testing at all in theory. I mean, people are doing it. emergency, acute sensory neural hearing loss or ototoxic testing, and everything else is remote. So to answer the question of what are we doing, well, I'm doing a lot of virtual balance clinics, and virtual clinics are absolutely fantastic for balance. And Louisa Murden and we've just submitted a paper to JLO. If there's any JLO editors out there, can you accept it, please? And then we're doing an audit on it, and we've got some other research projects, and it feeds very nicely into the artificial intelligence thing that I set up with IBM, which is a really big, exciting project. We're very excited about that over time. And if you think about it, you can take the history, and most of balance is done on the history, and then you can do, finger nose testing, under here. So I get the patients to touch my finger, touch their nose, do dysdiadochonesis, I do Rombergs and Unterbergs. I then get them to get their smartphone and go and lie on their bed and roll side to side. And I can do lateral and posterior canal, BPPV I can diagnose, and I've done barbecue maneuvers and Eplis and all the rest of it on their bed, virtually. So you can do a huge amount of balance medicine virtually. But what are we doing now is we are now beginning to start doing a lot more face-to-face, because I think the risks, even in Leicester, the risks are falling. So, 1 in 2,000 of the population have got coronavirus at the moment. Then of those, presumably half are symptomatic. So your chances of seeing someone symptomatic are very, very small indeed. And if you're properly attired, the chances of you catching it are beginning to be vanishingly small. The problem is that at the moment, you're not able to access, in most hospitals, good quality vestibular investigations. And even audiometries are struggling in some hospitals. And that's because NHS England haven't published this guideline. But I think, it was literally at lunchtime today that I did this, that I'm hoping in the next week that will be published, and then that will liberate us to do effectively what we want to do. And so the bottom line is just be sensible. Am I doing intratympanic injections? Absolutely. I'm still doing plenty of intratympanic injections. Am I putting grommets in? Yeah. And local in clinic if need be. If you're doing a Hall Pipes or a Seamont, I'll wear a mask, I'll wear a visor. There's one other really important thing that we wrote to the ministers about, and that's clear masks. Because of course, 1 in 6 of our patients got hearing loss, so they can't understand us when we're wearing a mask. And so you need to think about that when you're doing your otology clinic. And you might want to, what I'm doing at the moment, because we've got no supply of clear masks, I'm simply wearing a visor and keeping 2 meters away. But I don't necessarily have the right answer for that. And so that's a watch this space. Does that answer the question? I don't know.
Peter, it's Sandy here. I'm still here, believe it or not.
I am.
As much as I have zero interest in dizziness, but it's been a fantastic.
No, Sandy. As much as you had zero.
I hate to burst your bubble, Peter. I'm just sorry. On the other, with my other eye, I've been looking at the news, and they've just announced Leicester is going back into lockdown again. There's just been an announcement by Matt Hancock, so you're not going to be his greatest fan, I'm afraid.
But no, it's fabulous. It gives me 15 minutes extra in bed because I can drive into work really quickly.
No, you're going back in total lockdown, I'm afraid.
That's fine by me.
I blame you entirely, but fantastic talk, Peter.
Thanks, Ellie.
It's fantastic. I'm going to have to dial out, but I'm sure there's a few more questions that need answering, but amazing. Well done.
No, I think everyone's been, thanks, Andy, but I think everyone's been very strong and brave. So are you happy with that, Rishma?
Yes. I just don't want to miss out the 2 questions left.
Okay.
Just the last 2, which are, how would a patient describe non-spinning vertigo?
Oh, vertigo is an hallucination of movement. So spinning is only one sensation of it. So some people feel they're dropping or moving side to side, moving backwards and forwards. All of that can still be vertigo.
And the last one, what medications do you choose for a vestibular migraine? You don't have to talk at length about vestibular migraine, obviously.
No, that's absolutely fine. So I find about 2/3 of patients respond to conservative strategies. Caffeine is the biggest one. Cheese, chocolate, Chinese food, citrus fruits, and etc. You need to talk about. Keep yourself very well hydrated. Make sure it's not exercise-induced migraine. Make sure they're not skipping meals. So skipping breakfast is a big migraine trigger. make sure they're sleeping properly. People have the weirdest lives, which are migraine triggers, etc., etc. My first line medication in patients who don't have a history of cardiac dysrhythmias is amitriptyline, 10 milligrams nocte, 12 hours before they get up in the morning, increased by 10 milligrams a month up to a maximum of 60 milligrams at month 6. I'm not a huge fan of propranolol. The neurologists use a lot of propranolol. I just think it makes people feel absolutely rubbish. And then after that, you can use SSRIs. In fact, surprisingly, they're not bad for migraine. And then you can go through to topiramate. That's got a lot of side effects, topiramate. Some of the ladies like it because they lose weight with it. And in younger patients, in the teenagers, pizotifen is popular as well, but you can put a little bit of weight on with that as well. So generally, I mean, you've got to do what you're comfortable with. I would stick with amitriptyline or propranolol if you're comfortable with those. Those are pretty safe medicines. And if you want to go through things like topiramate and the other drugs I've mentioned, verapamil, I personally would get a neurologist to see them.
Okay, fantastic.